Well, welcome everyone. We want to show an interesting patient with critical limb ischemia. So this is a 92-year-old female who is actually relatively as healthy as 70, very active. She has mild aortic stenosis and hypertension. That's really all her comorbidities are. And she has developed a non-healing ulceration of the left great toe. She was being treated by a podiatrist in the wound care clinic and underwent vascular evaluation, was found to have a totally occluded left distal SFA, hence was referred for peripheral angiography and endovascular revascularization. So hence she's here today. So this is in our laboratory, this is a very classic presentation of patients, how they come here with critical limb ischemia, severe peripheral arterial disease, advanced age, comorbidities. And this is sort of our day-to-day bread and butter procedure. But what we wanted to show here is that how we manage this type of patient. So you can see that our primary approach is contralateral when it's possible. So we actually use the micropuncture set in this patient. We like a micropuncture set for these elderly patients with calcified arteries in the common femoral and other locations to reduce potential bleeding complications. And after getting an access with the micropuncture, we put a rim catheter, which is our classic catheter to do a contralateral pictures. And you can see that the inflow is fine in this patient. There is no disease. In the iliac system, the common femoral is okay. This is the remainder of the left lower extremity angio. There is some mild disease in the proximal and mid SFA. The profunda is okay. And the SFA, you will see in the next picture, is totally occluded distally with a lot of diffuse disease. And it's a short occlusion. And this is a catheter placed into the distal SFA to image the occlusion. So typically, our choice of wire for crossing long FemPop CTO is 035 stiff Tromoglide. But this is the kind of situation where we use oven 4 wires to cross the CTO because this is relatively short, a fairly easy CTO to cross. So in this case, we use the Gaia second, which is a coronary CTO wire that we also use quite frequently in lower extremities. There are many other CTO wires that you use, but that's the wire of choice. In this particular case, I took it because I thought that the lesion was not so heavily calcified. That's number one. It's a relatively short, straight segment. And you can see on the image that the Gaia second was able to get through the total occlusion without much in a way of a great challenge. Now, what could I have done if the Gaia second would have failed? There are multiple other options. We could have used Pilot 200. We could have used Confianza Pro 12 gram, or we could have just switched over to a Tromoglide. All of those can be utilized. So it's really an operator's choice, but this is a very, very nice case for a sort of a luminal crossing, if you want to call it a luminal crossing, with an oven 4 wire. And then I just advanced the quick cross catheter. This is an 035 quick cross, which I was using, and I changed over from a CTO type wire to a Grand Slam oven 4 wire, which is our workhorse wire in the periphery if we were doing work on an oven 4 wire. So I decided to do a laser atherectomy in this procedure because I do not believe that this lesion is very hard. So this is an 1.4 millimeter Turbo Elite laser catheter. So we'll make a pass with the Turbo Elite catheter And after making a pass with the turbo elite catheter, we'll perform an IVUS exam to then determine the effect of the laser and see if we need to use a larger device to do further debulking. So clearly, internationally, the use of atherectomy is significantly less than in United States. I think that this can be argued in many different ways. At least in our practice, it is a standard of care. We perform atherectomy on all of these bulky lesions because we feel that by reducing the amount of plaque, whatever the ultimate technology that we use, whether it's stenting or a DB, has better result. But I do agree that in Europe and in Asian countries, the use of atherectomy is quite limited. But certainly in US, atherectomy would be fairly standard in this procedure. So what CLI is going to do, so I have this set up at 60-40. And if Jeff can show the laser machine and the laser screen. So it's a 60 millijoules at 40 times a second. So Lauren's going to change the setting to 60-40 now. Okay. So important thing to remember with the laser, it really should be 0.5 millimeters distance per second and should always be associated with a saline flush. So I've already flushed the sheath several times to completely clear the artery of any dye. Because there is an interaction between photoablative energy and a dye, you will create large dissections. So we don't do that. So now CLI will start flushing. So I'm going to allow a few seconds for the flush to get to the tip of the laser and step on the paddle, please. So without injecting any dye, I'm going to perform IVUS examination. And the vessel is quite small, as you can see, 3.5 millimeters in the popliteal artery. And this is all disease segment. And this is where the severe disease is. And we have created a nice channel where we could use a larger catheter. So we'll get a 2.0 laser catheter and make a pass with a 2.0. A lot of disease. It's about 5 millimeter vessel here. So there is taper in this vessel. Lot of disease here. Okay. So this is kind of the area up to which we have disease. So we have to treat pretty much the entire distal SFA and practically the whole length of the popliteal artery. Okay, so we can stop recording now. So we learned a lot from this exercise. Okay, so this is the 2.0 laser catheter, and 2.0 laser catheter is large enough in a 6 French sheath that we should not flush through the sheath. We should actually flush through the catheter. So what I'm going to do is I'm going to show you a setup on how we do it, and you know, I'm sure that there are other labs which does somewhat differently. So I'm going to put the wire through the catheter, and I'm going to put a Y connector at the end of the laser catheter and actually connect our flush directly into so by this way you can see this setup. This is the Y connector, this is our assist flushing port, and CLI is going to flush. So you will see here, flushing please, that the flush is coming out directly at the tip of the catheter, because this cooling is going to be critical with this large catheter. And now the process is essentially the same. We're just flushing differently, that's all. Okay, step on. Okay, off. So based on the IVUS, the distally the vessel was 3.5 to 4.0. I've taken a 4.0 by 200 angio score now. We're going to do a balloon dilatation. Okay. Yep, go ahead. Okay, we'll leave it there. So this is a 4.0 by 200 angio score. I'm going to do prolonged inflation in the SFA and a popliteal artery, and then we'll decide what to do. So we've done a prolonged inflation with a 4.0 by 200 angio score balloon, and now we're going to do some repeat angiograms here to see if we need to implant stent. It looks really nice. Yeah, so I think that what I'm going to do is I'm going to prevent an urge to stent this. It looks reasonably patent. I do not think that I'm going to use a drug-eluting balloon here, as in the randomized trials, the patients with Rutherford classification 6, 5, and 6 were not included, and the lesion length is also significantly higher. So, yes, intuitively, someone could potentially argue that we could use it, but we're going to hold off until we do below knee intervention on this patient, and after we finish with the below knee intervention, we can then consider whether we want to pursue an additional inflation with the DEB, or should we be satisfied with what we have. So now we should be able to see a below knee anatomy better. So we have the disease in the tibioperoneal trunk, and of course we need to do angiography all the way to the foot, given the patient has an ulcer, to make sure that there is one vessel that reaches the foot, and the peroneal flow is slower, but the posterior tib is a nice vessel. We're going to do a foot angiogram. Here I'm pretty confident that if we treat the tibioperoneal trunk and this vessel, the patient is going to have healing. But for academic reasons, I would like to show you a foot angiography to demonstrate that the patient's plantar loop fills continuously through the posterior tibial artery, and we do not need to open up and occlude an anterior tibial artery. So here in this case, for TP trunk, there are many options. This is an excellent case for an implantation of a drug-eluting stent. So that's what I'm planning on doing. So we'll do a roadmap here. And let's put a 3.5 by 28 absorb. So we like absorb technology. I know it's been under investigation outside the United States for peripheral arterial disease, especially below knee disease. And it's a good option given that this stent will dissolve over time and allows future procedures on this vessel. However, in this elderly patient, perhaps we can argue that that doesn't matter, but this is a really good option for this lesion. So this is a 3.5 by 28 absorb DES. Now, unlike coronaries, we are much more relaxed in implanting absorbs in below knee vessels regarding preps and etc. However, we will definitely follow the guidelines for post-dilatation. So perfect length just between the origin of the AT and bifurcation. So I'm going to go ahead and deploy this at 12 atmospheres. Looks good. Nice expansion. May I have a 4.0 by 20 non-compliant balloon track and see. Coronary. Yes. Yes. 4.020. So I'm going to use a coronary non-compliant balloon to post-dilate the stent. Absorb should always be post-dilated, whether it's in a coronary or periphery, which is what we're going to do. Now.
14.
So I'm going to match the marker to marker. So there is a marker there. Okay, CLI inflate. Down.
14.
And I'm going to come up at the top and match the markers. Inflate again. So this is a coronary non-compliant NC track balloon at 14-16 atmospheres. Okay, down. So in coronary, we use ultra high pressure inflation from size 1 to 1. Here, we know that we have slightly oversized the balloon in comparison to the stent in the artery diameter that we use. So 14 atmospheres should provide good enough expansion for this location. We'll repeat an angio here to make sure it looks good. And I was confident that it should. All right, so now, as we have given some time for the artery to sort of relax, we're going to reevaluate this segment to see if there is a significant recoil post-balloon. Still looks very acceptable. Some minor dissection in the popliteal artery. Okay, so this is the pop here just below the knee joint. The vessel, yes, please. So this is the dissection that we see. So based on the IVUS, I'm going to pre-dilate this vessel with a 5-0 and then either repeat the angiogram and then decide whether the stent is still required. Yep. So this is a 5x250 ultraverse balloon, which is an 014 monorail device from Bard. Okay, that's good. Yeah.
10.
So this is a follow-up angiography after dilatation with a 5-0 balloon, and you can see that the result looks excellent. The flow is very fast, and this is in the SFA. That also looks great. We'll do one more below knee injection here to make sure that there has been no embolization. I don't believe so, but I want to show anyway. Looks great. The flow in the PT is very fast. So that should conclude, and that should be adequate result for this patient, and concludes this procedure. She should have a nice healing of her toe and a good flow. I'm going to do a completion angiogram here on the right side, and then we'll put a closure device in.